very little of medical education is about forming human beings. Most of medical education is quite dehumanizing, in fact, and medical training and medical practice, similarly dehumanizing. So where does this work of forming or shaping good doctors happen?
Public health officials are referring to the current season of respiratory illnesses as a triple-demic, with COVID, the flu, and RSV converging. According to the CDC, it's the worst flu season in 2 decades, and hospitalizations due to RSV are 8 times higher than average. The intensity of this triple-demic raises an important question. How well is our medical system equipped to respond? To answer that question, we typically look at material resources, like hospital beds, adequate staffing, or access to the right medicines, the last of which has been particularly challenging this season due to the shortages of antibiotics, antivirals, and even children's Tylenol. But material resources are not the only things that our medical system needs to respond well to health crises. We also need systems and professionals who can see patients as whole people and consider the moral and ethical dimensions of their care. That's why I'm delighted to share with you my conversation with Dr. Lydia Dugdale. She's a practicing physician and medical ethicist at Columbia Medical School. We talk about medical ethics, morality, and how the historic pledge of the medical profession, the Hippocratic Oath, is no longer required by any medical school in the United States. If this is surprising to you, you're not alone. I was surprised too. If the Hippocratic Oath is no longer sworn, what compels doctors today to act morally? How can doctors across disciplines and institutions agree about what's best for a patient? And what does this mean for your next doctor's visit? In our conversation, we talk about the decline of the Hippocratic Oath and what's replacing it, the purpose of medicine, and how we can all become better patients. This is the Veritas Forum podcast, a place for generous dialogue about the ideas that shape our lives. I'm your host, Carly Regal, and I'm the podcast producer for the Veritas Forum, a Christian nonprofit that hosts conversations that matter across different worldviews. So, Lydia, in addition to being a practicing doctor, you're a med school professor and a medical ethicist. And today in our conversation, I'd love to discuss medicine and morality. And I'm sure that you have a lot to say. But to begin, for our listeners who might not be familiar with what a medical ethicist does, could you give us a couple of concrete examples?
Sure. So thanks so much for having me. A medical ethicist could have a variety of functions, but I'll just explain what it means in my context, which is that I would maybe label myself a clinical medical ethicist, which means my role as an ethicist is primarily at the bedside of patients. In our hospital, which is about a 750-bed hospital in New York City, we are routinely called, we being the clinical medical ethicists, are routinely called to help resolve mucky moral quagmires that occur in routine patient care. So this might be something as simple as a patient needs a surgical procedure or an intervention but is refusing. Is it ethical to do that over the patient's objection or not? It might relate to having life-sustaining therapies, not just life support, where we think of the ventilator during COVID that was kind of all the talk of the town. But we now have portable life support in the form of pumps for the heart. Patients who are awaiting heart transplantation might be walking around with a pump under their clothes and a 7-pound battery pack over their shoulders to keep that pump going. If a young patient wants to have that pump discontinued, I might be called because the team wants to know, is this ethical to simply stop a pump that's keeping this man alive and have him die right here? So those are some of the issues that we get called about. And I'll have to say that in New York, where there is no end to the amount of social problems, these ethical conundrums really are routine. We are called all the time. because these problems manifest. And sometimes we just need to clarify the law, what's legal. And sometimes we need to actually kind of investigate and figure out what is the ethical, the legal, the practical thing to do. That's clinical medical ethics.
When I think of medical ethics in a more theoretical sense, I think about the Hippocratic Oath, which you have recently written about for Plough magazine. I think in my mind, as someone who's not trained in the medical profession, I see the Hippocratic Oath as sort of the framework that guides ethical action in medical spaces.
One would think.
Yeah. So can you tell us about what's up with the Hippocratic Oath today? Is it still a thing? What even is it? Just a general primer would be helpful.
Sure. So I'll say Plough asked me to write this piece on the Hippocratic Oath. And I said to them, that's all fine and good, but we don't take the Hippocratic Oath anymore. And they said, oh, well, that's interesting. We all thought that doctors take the Hippocratic Oath, do no harm. And I said, no. We don't take the Hippocratic Oath in its original form at all. So what's going on with that? Well, Hippocrates was a real guy, probably lived sometime in the 400s BC. And he was a physician, and he was a physician that belonged to a sect or a clan called the Asclepiads. And they were a group of doctors who were devotees of this god or demigod of health called Asclepius. And their thing was that they were not into quackery. So they felt very strongly that medicine should help, that it should be oriented toward healing, that it precluded killing. Hippocrates and his followers then, within this Asclepiad tradition, had a number of writings. It's hard to know, who wrote what, but generally we think that there are probably 70 writings that could be ascribed to Hippocrates and the Hippocratic tradition. One of these was the Oath, and what's now routinely referred to as the Hippocratic Oath. And the Hippocratic Oath, of course, says, we belong to Asclepius. We swear by Asclepius and some other gods. And we're going to hold our teachers in high regard, almost as if they were our own parents. We are going to be oriented toward healing. We are going to help and not harm patients. There's a certain purity that is required of us, that we are going to be pure and holy in our life and our art. And we're going to refrain from all sorts of wrongdoing. We're not going to break confidentiality. We're not going to perform abortion. We're not going to have sex with our patients. We're not going to euthanize patients. All these things we're not going to do either. And this was the Hippocratic Oath. And I'll just tell you, to give you a sense of what's happened to it. This hasn't been tracked very carefully, but there was a study that I found in the medical literature from 1928, which was published in a mainstream medical journal. And at that time in the 1920s, they had surveyed medical schools. And of the 79 medical schools that responded, only 14 still took the Hippocratic Oath in its original form. So even by the 1920s, the vast minority of medical schools swore the original oath. And today, nobody does. Not a single medical school in the United States swears the original Hippocratic Oath.
I'm curious about, obviously, even in the 1920s, there was a shift away from the Hippocratic Oath. But as you mentioned in your article, oaths are still taken by medical schools. And I think it's interesting to think about, maybe there's been a shift away from the Hippocratic Oath in particular, but it isn't as if oaths have been completely gotten away with. I guess I'm curious if you have any insight on what is replacing the Hippocratic Oath.
Well, it's a hodgepodge. I quote this one ethicist and his colleague who sort of bemoan the boutique oaths that are taken today. Boutique oaths can lead to fragmentation and confusion about the ethical values of the medical profession, they say. They're sort of concerned that these boutique oaths dilute the value of a professionally binding oath. Now, that's certainly up for debate, but I think the intention of young medical students, young trainees, is a good one, which is to attempt to articulate what we stand for, what we believe. That's a very noble goal. The problem is to do this in the absence of any sort of guidance or tradition or moral framework. And I'll tell you that when I was writing the Plow piece, I found my medical school's student version of the Hippocratic Oath written by the incoming class from a year ago. Let me just say that it would have benefited from having Hippocrates or Socrates or Aristotle sort of hang out with the students and give some guidance. And it's kind of beautiful and cute that the students were attempting to put this down. But you can see how, in the absence of any sort of unifying moral framework, it really does become hodgepodge. And that just underscores how the practice of medicine has lost its way. There is no moral guidance. There's no ethical framework that medicine sort of writ large, uses to know how to move forward.
How do you see med students today? Is there an area of alignment with Hippocrates and his original vision of medicine? Where do you think med schools today are doing the best work in regards to moral direction or morality in general? That's a very broad question.
It's a good question. Most medical students, for example, have very little exposure to traditional medical ethics or philosophy courses. There's so little. And medical ethics or philosophy is where people typically in a secular space acquire their kind of moral vocabulary, their moral language. One of the things that drew me to medical ethics as a discipline is that it felt like the space within secular academic medicine where one could talk about the moral life and really talk about high stakes issues in a deliberative and deliberate way. So where is it happening? There's so many things that are required to be taught and learned just to get a medical degree, which means that anything that could be extra is made extra. So many aspects of medical ethics are made extra. Most medical students have 1 hour in 4 years on delivering bad news. I don't have an exact statistic, but my guess is that most medical students have maximum 1 hour on talking to patients about death, if they have that at all. You know, when you have an interaction with a doctor and you feel like, wow, this person's really not a human being. What happened to this doctor? Well, very little of medical education is about forming human beings. Most of medical education is quite dehumanizing, in fact, and medical training and medical practice, similarly dehumanizing. So where does this work of forming or shaping good doctors happen? A lot of it happens outside of the mainstream curriculum. And I can tell you that that's the case here at Columbia. We have several different initiatives to build community and make space for important conversations and reading together and sharing meals together. Yeah, just this morning we had a book club that met 8 a.m. to 9 a.m. over breakfast, and we've had about 25 or 30 students be a part of that this fall, all elective. And not even formally elective. It's not that they get credit for it, but because they recognize that there is a need to engage in conversations about what it means, not just to be a doc, but to be a good physician, good in that robust, virtuous sense of the word good. And so my colleagues and I here in the Ethics Center at Columbia have worked really hard to try to create these spaces for our students. As a product of this education myself, American, sort of academic medical education, there's such a need for more of it.
I love your comment on what makes a good doctor in the very robust sense. I'm curious if you were to suggest a mandatory element of medical school or medical education that had to do with making people into robustly good doctors, where would you start?
Probably have them read Aristotle over food together. I mean, that's what we're doing right now with another one of our initiatives. And it's fantastic. They read a combination of Aristotle's ethics with some philosophical articles on technology, on death, on embodiment, on what it means to be human, different topics like that, on the effect of space, on formation, right? How do our environments shape or misshape us? How do they form or malform us? And the hospital can be a very malforming environment. So we have these conversations. The students have to do quite a bit of reading, and then they show up once a month over dinner to talk. And we're really building a lovely community of engaged and thoughtful doctors. But yeah, there's not a lot of space, so we have to get creative.
Shifting gears a little bit, I am thinking back to the examples that you gave at the beginning of this conversation. I'm curious about what legal, ethical, and practical looks like in the face of uncertainty. I'm thinking specifically about like really difficult treatment options. I guess I'm curious what your relationship with uncertainty is as a medical professional.
Yeah, no, I have quite a nice relationship with uncertainty. I don't know that all medical professionals share my same comfort with the ambivalence, but I'm okay in that space. I'll give you sort of an example. This isn't a true example. I mean, it's not false, but I also, because of patient confidentiality, I'm not going to give you any single patient's story. But imagine, for example, you have a 30-year-old woman who's been diagnosed with cancer, and the diagnosis is terrible. And just before her diagnosis, she'd given birth to her first child, married a couple years ago, etc., right? Young family, young couple, first baby's a couple months old. And now this cancer is terrible, and the only treatment available might also cause some other organ failure. But it might give her a few more months of life with her baby. That's only 2 months old. So do you take the risk of trying this therapy that might give her more time, that might also cause a major organ to fail, without which she would die? Or do you let the underlying disease take its course and she'd probably be dead within the month? Any of those options is legal, right? Is any of them ethical? Well, probably any of them is ethical. They're probably all ethical. The goal is to do what's best, but we don't exactly know in that sort of a scenario what the best outcome would be. So, ethics has been called to the bedside to help weigh in on these cases, because sometimes the treating clinicians want to know if, in our view, one is more ethical than the others. And then, of course, all of these issues have to take into account how the patient or her family are thinking about these options as well. It's not uncommon for us to have to clarify what is legal. What is legal is not always ethical, and what is unethical is not always legal or illegal, right? These things are not the same. Something might be perfectly ethical and perfectly legal, but not at all practical. So if you have a patient with dementia who would benefit from a therapy but is refusing it in the state of having cognitive impairment and dementia, but you know that this therapy is ethical, it's legal, it will prolong her life by years, but it's going to require, let's just say, daily radiation for weeks and weeks and weeks, for which she has to lie perfectly still under a radiation beam. That might not be practical, because that to keep her still would require deep sedation. So, right, there's different ways to think about these things. And so sometimes our role is just to try to wade through all of these different details and help people adjudicate. But we need to get clear on what the details are to be able to make that adjudication.
I'm thinking about the age of WebMD. I'm thinking about instances where someone has done a lot of research online, is very convinced that they have such and such condition, or is advocating for some sort of treatment, but is maybe coming from a less informed position. From a medical ethicist standpoint, is there ever a time where you can kind of play the like, I'm a doctor trump card?
Well, the way the knowledge balance plays out in real life is that increasingly, and really for the last, I would say, 50 years, there has been a rise of the patient autonomy movement, which is to say, this developed in the 1970s in reaction to the idea that doctor knows best. In fact, patients said, we disagree with what the doctor decided. The doctor also is making a decision about quality of life. The doctor also is making a decision about whose life is worth maintaining. And the doctor doesn't know my values. And so to mitigate against a physician or clinician who might have a lower regard for certain people's lives, the pendulum is really swung both in ethics and legally to say, let the patients decide. Now, that's good on paper. It does become problematic when a patient is not informed, or we'll use the language in medicine of low health literacy. If a patient has low health literacy, they may not fully understand what they're getting into. Another group of people who may or may not make what some would consider to be the best decision about healthcare treatments are groups that have been historically marginalized or even experimented on. Right? They have a high suspicion of the medical system. And so, the doctor says that my cancer can't be treated. Well, that doctor's wrong. I'm going to go find somebody who will treat me. And of course, you can always find an oncologist who will offer yet another chemotherapy. But the question is, does that chemotherapy have any efficacy, or is it going to make you feel absolutely miserable? And so I think we've tried to be really careful about the sort of doctor knows best mentality. I'll just say that in New York State, where I live and practice, the way that the state sort of thinks about this kind of decision making is that somebody's going to make a mistake. Either the doctor is going to be too aggressive, either in maintaining life or in withdrawing life support, right, and giving up too quickly, or the patient or the family is going to make that mistake. And the law says, in a sense, in effect, the spirit of the law is we would rather have the patient or their family members make that mistake, right? We'd rather have the family members say, keep grandma alive, even though grandma is decaying inside, keep her alive, than have the doctor say, you know what, enough is enough. We're going to just pull the plug. So that's not true for every state. Every state, the law is slightly different, but you can see how, because there is a power imbalance, there's a knowledge imbalance, and there's always also an assessment of whose life should continue. Now, one of my encouragements, and this is particularly true in my book, The Lost Art of Dying, I strongly push people to prepare their questions and keep asking the doctors until they get satisfactory answers to their questions. Because many doctors just stop talking because you can give information overload. You don't want to overwhelm families. It's already a difficult time. But there are answers to the questions. And so if pushing for answers would help you as a family to make decisions, keep pushing for those answers. And I go through some of that in my book.
I'm curious about, from a ethics point of view, what does do no harm look like in that dynamic?
Yeah, that's a great question. I mean, every case is different for sure, but do no harm could mean, so, the patient does have a lot of power. If a patient comes in and clearly has an upper respiratory infection and demands antibiotics, which I can tell you as a primary care doctor happens all the time, and I say no, the patients can get mad at me, but I explain about, the science behind it and why we don't and what to look for and when you might have a bacterial superinfection on your common cold. And try to teach. The word doctor in Latin means teacher. I try to teach. Sometimes patients leave disgruntled, but hopefully they can leave knowing that, okay, there are parameters around which the doctor will give me antibiotics, but let me go home and see how I do. So do no harm in that instance for a common cold would mean definitely no antibiotics, because taking any sort of medication has side effects. It's just the way it is. It gets trickier when people come in and demand things that a clinician might find morally objectionable. So I have had multiple patients ask me for lethal drugs so that when they are ready to die, they can take their lethal prescriptions and die. Now, in Illinois, where I was a medical student, and in Connecticut, where I practiced for a long time, and in New York, physician-assisted suicide or aid in dying is illegal in all of those places. But were it legal, I would have to have a similar conversation. And this is where I have a colleague who's at Duke University, Dr. Farr Curlin. He's written rather beautifully on candor with patients. Just like with my kids, I say, this is the way it is. This is why mom said no. This is how I want you to think about it. I have to do the same thing with my patients. And again, this is not to say my goal with patients is to be paternal or maternal in the way that I am with my children, but it is to say that if I'm going to decline to give someone lethal drugs, I also need to explain why, where I'm coming from. And that's why I love that language of candor. And so even for my patients who've asked me for lethal drugs, I'll just say, look, you need to know, first of all, that it's illegal in this state. But were it legal, this is the way I think about it. I do believe deeply that the profession of medicine is one that is oriented toward healing. And therefore, interventions that don't seem like they are for healing, which making a patient dead is one of those, for me are outside the bounds of what I am willing to do as a physician. Now, I know that there are others who feel differently. But I need you to know that if we're going to continue to work together and if legislation is pushed through, this is the stance that I'm going to hold to. So I just try, but I'm also happy to keep being your doc. I'm not pushing you away, but I do want you to know where I'm coming from. And so I think that's helpful, right? There's no misunderstanding. We have it all out in the open. Good communication is so important. It's important in all relationships, not least the doctor-patient relationship. And I think that's part of the way that I can serve my patients, is to make sure that we're on the same page and have clarity about where each other stands on difficult issues moving forward.
I kind of see the medical ethicist as someone who navigates the waters of what is right and what is wise. Would you agree with that?
In a world that perhaps one could say suffers from a lack of any kind of moral absolutes, it's hard to say that there's a distinction between what is right and what is wise for the ethicist in a secular place. At the same time, I think the language of practical wisdom is probably language that resonates with me. And it also then suggests that different situations, different cases, different patients might have similar scenarios, but what is practically wise for one may not be practically wise for another.
This notion of practical wisdom, you've mentioned a couple of different sources over the course of this interview, like Aristotle, Socrates, just people in virtue ethics in general. I'm curious, Lydia, if there have been elements of the Christian tradition that have been especially helpful for you in practicing medicine or in being a medical ethicist?
What immediately comes to mind is the scripture, "Do not grow weary while doing good." Medicine is the long haul, the training and preparation, and then practice can be, I've already mentioned that the way it's structured is very dehumanizing. But at the same time, the work really is good work. It's a good thing. It's a good gift to care for the sick and the vulnerable. And it's really easy to grow weary and lose heart. But I think we're called not to grow weary and lose heart, not to give up doing good. I also think regularly of the admonition not to think of others better than yourself. Physicians still do have a lot of clout in the medical hierarchy, and yet I think about this regularly, and I know many of my colleagues do. When you're caring for someone who's your same age and stage of life, but that person has just received a devastating, life-altering diagnosis, it's hard not to wonder why it wasn't you, right? There, but for the grace of God go I. And so, because it is not me, I have to continue to serve, right? Not see myself as anything better, but continue to serve, not grow weary while doing good, and serve because, so much has been given to me. So, yeah, there's a lot from Scripture that can be sustaining. I think the bigger challenge is to try to figure out how to make reading the Scripture and times of quiet and meditation part of the daily chaos of the clinical day. And I think that's a real challenge for a lot of young doctors in particular.
Well, as we end up this episode, I would really love if you had any advice for those young doctors or medical students, specifically regarding the sort of medicine as a moral practice idea that we've been talking about today. Do you have any advice on how they can grow, how they can become wise in a medical sense?
Yeah, I mean, the biggest thing, and I probably haven't said this enough, is that the moral life was not meant to be practiced alone in isolation. And so much about our training and our work life and the American life is about that rugged individualism. But to grow in the life of virtue, we need one another. Hippocrates would say you also need an exemplar. You need that teacher who's going to walk with you through it, and your co-laborers, your co-students who are going to walk with you through that. So, yeah, I guess for anyone listening, make sure you have your community of folks who are laboring together, encouraging one another, building one another up, bearing one another's burdens, and pressing one another on to love and good works.
That's great. That's great. I think that can apply for everybody. My last question for today, for those listening who are not in medicine, but may find themselves in a doctor's office, how can we be better patients?
If you take a lot of medications, bring in your medication list and make sure it's updated. That will save lots of time. How's that for very practical? It's interesting to be the one who's constantly caring all day for people, and to know that you can go through an entire day and not hear a single, "No, but how are you, doc?" Or a thank you. It's amazing. It's amazing how many days I've gone through where no one has asked. And, that's fine. Like, I'm not in it to have a thank you, but I'm not in it for any of that. But it is amazing when a patient remembers that I also am a human being. That's a gift. And it's actually an encouragement to keep on in the work. There are different work environments that we are called to or we find ourselves in, and everyone needs a little bit of an encouragement. So if you're at the doctor's office, take your medication list, make sure it's updated, but also just let's all work on being more engaged in inquiring after the other and really seeing one another in the fullness of our humanity. I think that would be a good goal for us to press toward.
That's an incredible note to end on. Thank you so much, Dr. Dugdale, for joining us. It was great having this conversation.
Pleasure.
Thanks for listening to this Winterlude episode of the Veritas Forum podcast. In a few weeks, we're beginning the 12th season of the Veritas Forum podcast. Our spring season is all about meaning and purpose. So if you're wondering what to do with your life, how to find meaning in mundane days, or what success should look like, be sure to subscribe now to have new episodes from the Veritas Forum podcast pop up in your podcast feed. Our production is led by me, Carly Regal, and the team at Resonate Recordings. Thanks to Bethany Jenkins and Seth Bollinger for providing content editing and audio support for this episode, and to Heather Beloga for coordinating all of our production needs. Thanks to our guest, Dr. Lydia Dugdale. The Plow piece by Dr. Dugdale that we reference in this episode is linked in the podcast description. Also, be sure to check out her book on end-of-life care, The Lost Art of Dying, which is linked as well. Thanks also to our incredible partners who help support Veritas and make sure these conversations are possible. And a final thanks goes to you, the listener. Be sure to mark your calendars for Season 12. Our first episode drops in February 2023.